ACT is such an intensive set of services. It's so individual that each person is known every single day. If you're a consumer, you're talked about. You're reminded at the team meeting. You're remembered. If you happen to have called the night before in a crisis, the team knows it in the morning. They can just immediately reschedule so that you can get the attention you need.
How many of you see the patient without a team member in the room? Okay, let me tell you the problem with that. Two problems. One is that the patient is more likely to want to tell you secrets. The other problem is when you and the patient decide what to do, you don't have team buy-in. You go to the team and you say, I've decided with the patient that we can stop their Zyprexa. Having a team member in the room, that individual then is responsible to sell what the patient I have worked out to the team. And that person may say, hey, we really need to talk about this as a team before we implement this.
We all have really different ideas. We all talk and come up with a solution for the client that is clinically based, not for the benefit of the group, our group, but for the benefit of the client. And I can say that that happens every time here.
Team fits in because they see me more often than the psychiatrist does. So they, so they can fill the psychiatrist in on stuff that they noticed about me that I don't notice,
Pick up that phone and call, communicate with a primary care provider who's also, at the verge of throwing up his or her hands and saying, no, this is all psych, go to your psychiatrist.
I think our team gets frustrated that we will do a clinical meeting with the doctor in the morning and let him know how the people are doing that he's going to see that day. And then when he actually sees them, that everything gets addressed or followed through. They'll convince the doctor of like anything and everything that, wait, this is the first time we're hearing of this, why didn't you tell us this? Oh, because they just made it up,
Use the team as your eyes and ears in the community because you can't always be there and you can't treat patients as difficult as this without having eyes and ears in the community and knowing what's going on.
You're going to be engaging individuals who have diverse backgrounds, who with those diverse backgrounds come diverse worldviews, whether it's religion, spiritual beliefs, or others. And you're not only going to be engaging these individuals, but also engaging the diversity that exists within the staff that are involved in caring for these individuals.
We need to link up the goals of the patient with the treatment plan. We need to help them to understand why our recommendations in the treatment plan that we're all collectively agreeing on, why it's important, how it's going to help them to get to where they want to be in their life.
To talk to them, because they're so knowledgeable about mental health. Mm-hmm. And sometimes I get good feedback, when I'm talking to them. Like if something is bothering me, and I talk to a psychiatrist, it all seems so worthless, for me to worry about it.
I don't know how it disrupts the nervous system. Somebody needs to be teaching me that. I'm educated. And they don't do any education to say, here's what's actually happening in your body, or this could be happening, or it's happened to other people.
The more teaching, education you can do about their meds so they understand why they're taking them or why they shouldn't use alcohol or illicit substances, why they're on their meds, helps increases the chances that they'll be med compliant. I mean, you have the staff on the team seeing these people in their homes, in their own environment, and they know them better. But then when the client gets in with the doctor one-on-one, well, not one-on-one because I sit in on those, you know, they'll convince the doctor of like anything and everything that, wait, this is the first time we're hearing of this, why didn't you tell us this? Oh, because they just made it up, you know?
Listen to your team, you know, and that kept me alive I don't know how many times, because I'd get one of them swayed, but I could never sway them both at once. And so they've got to really stay on top of your team. They're the people that know your client.
I wasn't working, a bunch of stuff happened, and no one really wanted to tend to, you know, what's happening with how you're feeling about all that.
Why I have trouble solving them, but a lot of it has to do with the hallucinations and you know, things that that plague me every day.
I mean, if there's anything that we've learned through studying patient-clinician interactions, is that patients remember very little of what was discussed in this session. In recognition of that, I think it's incumbent on us to provide a lot of written materials to try to get over that important hurdle to effective treatment.
I was out on the highway and I saw some cars going 75. Have you seen that? Or is that new to you? 75 is hypomanic, right? You're going faster than normal. You're getting more done than normal. You're not setting up any dangers. You wave at the police driving by. 75 beats 70, right? Okay. Now you start going. Your landlord, somebody else gets offended by how you're doing your righteous indignation. Then the mixed state. We used to think that you had only one leg, mania, depression. Turns out we have two legs, and you can have on the brake and the gas at the same time, and that's quite painful and trouble because that's always a very uncomfortable state. Irritability is the way it shows up. The patient looks manic to you, the patient tells you they're depressed, and we do create that. All right, you've been paranoid. Okay. How about if you turn a corner and the police turn the same corner? Now we're going to have two hands up. Okay, you're paranoid. Okay. What's happening is you are having a grandiose sense of yourself. You think that other people care more about you than they do. Okay, so if we've all been paranoid, then patients are just, it takes less to make them paranoid. But again, we're trying to normalize the experience.
I spent a lot of time being really suicidal, And one of the things that they did for me was they kept me alive until I wanted to be alive. And during that time, whether it was, you know, putting me in the hospital or giving me my meds every day, whatever it was, they stayed really focused on not just keeping me from dying, but getting me to the point where I had enough hope to live.
I think we need to provide a lot of written materials to patients. Obviously, we need to do that judiciously. We don't just inundate them with lots of paper where relevant information is like finding a needle in a haystack. I'm not saying that, but what I am saying is that we need to keep in mind that people do not remember much of what's discussed when they meet with the professionals, and I think that the more effective, concise, clear aids that we can provide to them, the better off they'll be.
She communicates with me. She'll ask me questions. You know, it's not like, well, how do you feel this way? Or how do you feel? It's communication in a different way. And on my level,